So big credit to the conference organizers for putting the patient on the agenda. I'd like to think that if this conference was being held a few years ago, the patients would be here for that one as well, but I'm not sure. It wasn't that long ago that CIHI and Infoway did a paper for the Conference of Deputy Ministers on analytics. I think it was health system use was the title of the paper, and I don't recall a lot of content around patients in that paper, but I think it would be different if it was done today. And I know, both Infoway and CIHI now, in their most current and recent strategic plans, have quite a big emphasis on involving patients and the role of patients. And we're hearing a lot from the provinces on the importance, and here in Ontario we have a minister who has a vision, a patient's first vision. So clearly patients are getting on the agenda. And I think we're also getting, and it was very much reflected in the session just before lunch, that it's not just a matter of sharing information with patients, but it's also a matter of listening to, including patients, bringing them to the table and having them from an early point involved in planning, decision-making, quality improvement kinds of initiatives too. So why include patients in health analytics? My own view is that there's huge potential value to patients in terms of giving them access to some pieces of health analytics, to the tools and things that can come out of health analytics. And there's maybe no better example than some of the suites, the suite of tools that John Hurdy's talked about yesterday, his Inter-Eye tool, and the potential for those to be used in ways that serve patients and clients of home care programs in a very useful, valuable way, and a way that serves the system as well. And I think we all recognize that we need to move beyond the point where data and information and access to these kinds of resources are used on an exclusionary basis. And I do appreciate Robin Tamblin's sort of opening, sort of her point about the things she would do on Monday if she had the chance. And I think at a more macro level, clearly there are significant roles for patients to play in shaping health analytic strategies and the design of health analytic tools. And we I think, should all be interested in getting that kind of getting the patient's inputs so that we're sure that those sorts of tools and the strategies really do focus on outcomes that matter to patients. I think we've, for a long time, recognized that part of the success of health analytics is bringing providers to the table, engaging them, getting them on board. I think there's a parallel with patients. So I think we need to recognize that for health analytics to be successful, I think one of the critical success factors is that engagement and successful involvement of patients. And so I guess, sort of in terms of my opening remarks, just conclude by saying, Dennis and Brent, when they opened this conference up, asked us to think in terms of opportunity, value, and action. I think those were the three things you raised, Dennis. And I would say that, in terms of patients, clearly there is still a huge opportunity there for involving them, for making things more patient-oriented. And I certainly think from an action point of view, if you want the action to stick, then bringing patients to the table is very much part of that. And it's all very easy to talk about this stuff. A lot of it is about cultural change, which is difficult and not easy to do. And I think we've still got a ways to go there. But I have to say I've been very encouraged by the discussion we had, particularly this morning, because I think it did indicate we're moving in that direction. So with that, let me introduce our speaker who's going to speak to this very topic. John Halamka is no stranger to dialogue about health analytics, and is probably familiar to many of you. He's the CIO of Beth Deaconess Health System. But more significantly for today's discussion, John has his own lived experience, both as a caregiver and as a patient. And I think the conference organizers have asked John to bring that to bear, as well as updating us a little bit on how that's playing out in the context of the US system. I know John was very keen to add sort of his insights from the US to the discussion that was going on immediately before lunch. So, John, we're really looking forward to your presentation and appreciate you joining us today.
Well, thank you, and it's so good to be back in Toronto. This is my third visit to Canada in the last 30 days. And why, Dennis, am I in Canada so often? Well, if Donald Trump is elected, 70% of Americans will be anxious, and 30% will be Canadian. And in fact, there was actually a big data analytics article in the New York Times last week looking at Sarah Palin's diction, and it actually does not follow any pattern of any known language. It is amazing. So thanks very much for the kind introduction. And I was asked not to use slides, but to reflect on a number of personal experiences as a CIO, as a patient, as a husband, as a son. Well, I want to start with, as a CIO, a number of years ago, the United States passed the Affordable Care Act, Obamacare, as you'd call it. And it signaled that we would begin to change our healthcare system from one that was focused on quantity to one that was focused on quality. And now there have been additional regulations passed, some reform, this macro legislation it's called, or the doc fix, that is going to move 25% of our Medicare reimbursement to outcomes rather than fee-for-service. And of course, did 3 years ago any CEO or government leader come to me and say, you know what we need? We need a big data analytics repository with the continuum of patient data, subjective and objective, with visualizations that'll change behavior. No. And in fact, I looked at the distribution of people who are at this conference, and we've got academics and government leaders and industry people, et cetera. The challenge is, as you go out to your stakeholders and you say, well, do you need population health? And they say, well, absolutely. I just have no idea what it is, but I'm not getting it, right? You don't quite know where it is you're going to have to innovate, what products or services you're going to have to build. So sometimes you just get lucky. So starting 3 years ago, here's what we did. I would love to say that the Beth Israel Deaconess health system has one unified EHR with seamless, accurate data capture. We have 26 different EHRs. How did this happen? By merger and acquisition. Alas, when you go buy a 2-doctor practice in some small rural area, you can't just say, we need your EHR replaced tomorrow. I mean, it might happen over time. It's just not happening quickly. So what that means is this heterogeneity of source data will persist for a long time. So if you're going to try to do care management or population health, what you need to do is take data from the point of care, and we'll talk about the kinds of data, because there's lots of different kinds of data, put it into some kind of common format, and then be able to provide actionable advice to clinicians and care team members based on that data. So here's what we did. We created in the Massachusetts Medical Society, it was Geneva, kind of neutral ground, something we call the Quality Data Center. We require for all of our physicians, for all those practices, even loosely coupled to Beth Israel Deaconess, that they submit 141 pieces of data on every encounter, inpatient, outpatient, urgent care, skilled nursing facility, any encounter. And so then, even though it's 26 different EHRs, and there's a lot of informatics behind the scenes trying to map that into a common format, we have a view that is patient-centric, to the comments you made. It is not provider-centric. It is not institution-centric. It is patient-centric. So that means I know where you visited, what care you got, what care you didn't get. Did you get too much? Did you get too little? Was there a good outcome? Was there a bad outcome? And it's all housed in one location, despite the fact the source data is very heterogeneous. Now, in Canada, I am sure you're going to have the same problem we do. I mean, maybe less so because of the way you're structured, but you're never going to get to one EHR. You're never going to get to one common data stream. So it's informatics hard work, as I said, to get this into some kind of common format. But once you've done that, what do you do with it? Well, we produce all our federal and state government quality reports from this singular database of the longitudinal patient experience gathered from all these different EHRs. EHRs are fine, but generally what they are dumb data gathering tools. I mean, and I don't mean to insult any vendor, but reality is the EHR was originally construed as a way to document an encounter within an institution, not to provide continuous wellness for a patient across their life. So assume the EHR may not be the place where you're going to deliver all your quality computations or your visualizations. Maybe third-party products or modules that leverage the EHR data. So we do all the quality reporting. Well, there's some other interesting things you could do. Use your imagination. If I know where the patient has been, and that means I know the PCP and the specialist and the hospital, now when the patient shows up somewhere, I actually have a sense of who would care. Who is interested in the fact that the patient just showed up in an ER across town? Aha, I could actually do what we call an event notification because I have history of where your care has been delivered in the past. So that means the primary caregiver or specialist in a publication subscribe type model can be notified of events that occur to you. And one of the things we're thinking about in terms of patient centricity is there are others on the care team other than MDs, nurses, social workers, and physical therapists. Mom, dad, sister, brother, people who may be part of your care continuum who would also be able to publish and subscribe to this idea that you just showed up and registered for care somewhere and data about that episode was transmitted to a singular database. We also have created a series of analytics. Now, I listened to all the program this morning, and I will tell you that providing actionable analytics is pretty hard. So here's an example of the kind of actionable analytics we've created. It turns out, and you may have this too, that 5% of our patients account for 50% of our costs. The challenge, of course, is you don't quite know who your super utilizers are going to be 2 years from now. So part of our challenge is using risk adjustment modeling, and I think we have a statistician somewhere in the audience, somebody who's actually a very important statistician, I've been told. It's very hard to do predictive analytics and to do risk adjustment with an R-squared much greater than 0.3. But we have been able to do a variety of models over the course of the last couple of years that help us understand that if you have, let's just imagine this, a creatinine that goes from 1.0 to 3.0, you're probably going to be on dialysis 2 years from now, and therefore if we can intervene now with intensive medical therapy, dietary modification, et cetera, we may be able to avoid dialysis in the future. Much cheaper to use your big data analytics database today, do home care visits and do a very significant structured intervention than to wait until somebody's sick. So what do we do in our care organization? We identify every year the 200 people most likely to be super utilizers 2 years from now, and we put a lot of resources into delivering services to them in their home and truly build a care plan around them. Now, I will give you a dirty secret, and I don't know, is this being taped? It's okay. We've only done this once. The very first year we did this predictive analytics statistical model, we bought Lloyd's of London reinsurance on each of the individuals we predicted would be sick 2 years in the future, and Lloyd's of London lost $10 million on the transaction. You can only do that once, but it did prove out that we are actually better using statistical models than the actuaries are with figuring out who may be an expensive patient in the future. So risk adjustment, that's interesting. Another thing we've done, and this isn't exactly a term of art, but we've created what we call the care management medical record. Now remember what I said is the EHR is kind of dumb. You know, it's gathering information on what is your diagnosis and what is your lab result and what are the appointments and those kinds of things. Does it analyze across a population of, say, patients with a specific disease, diabetes? Who in a population has not had a flu vaccine? Who in the population has had a hemoglobin A1C greater than 9? Who has not had an eye and foot exam? So we have care managers, not docs, but actually we'll call them team-based extenders, who are mining this rich data source to look for gaps in care, and then behind the scenes, scheduling appointments, scheduling services, making interventions where there are gaps in care. There is an interesting element to this because today the data is mostly EHR-based data. It's clinical and financial both. if we look at the patients and the patient's experience, there is a vast amount of objective and subjective data that only the patient knows about. And that is, does the patient know whether they're in pain or not? Whether they are happy or sad? Well, sure they do. The EHR, I think actually was said earlier today, doesn't really usually gather such things as social determinants of health or a lot about your day-to-day activities. So Beth Israel Deaconess has done a lot of aggressive mobile technology development over the last couple of years to start gathering data from patients in their homes, and it takes two forms. One form, which we call ePROS, the Electronic Patient Report of Outcome, typically used in our orthopedics department. After surgery, we are, I think to the speaker on the athletics side of analytics, we are asking such questions on range of motion, capacity to function with activities of daily living, exercise, sleep habits, all those sorts of things. But we're asking it subjectively. How do you feel? How are you acting? How is your recovery? What is your functional status? Is your wound red? Is there drainage in your bandage? Those kinds of things. Another part of the data is very objective. What is your blood pressure? What is your weight? What is your glucose? And today, if you go to Amazon.com, now, I don't know, is Amazon.com a good or a bad company in Canada? Is it okay? Okay. Yeah, see, I have to be careful because, like, in every country, and I say things like in Japan, there's this great website. I say, oh God, don't ever go there. But Amazon will sell you a blood pressure cuff from the Withings company for $79. It's Bluetooth low energy. It sends your blood pressure measurements to your phone. A bathroom scale, $50. Bluetooth goes right to your phone. So suddenly, we now have this rich corpus of patient-generated objective data at low cost on phones. It was not hard. It literally took about a weekend to write an app that with patient consent, because patients always have to consent, sends data from the phone to our care management medical records. So now you're looking at the benefit of EHR data, the doctor view, patient subjective data, patient objective data. And that really helps you when you think about managing wellness, achieving a good outcome, being respectful of patient preferences. So let me give you a couple of examples. And since I actually know many of you in the audience, I'm going to use examples you haven't heard before from my last two trips. And I do have to give you the preamble that my wife and I and my daughter and my father and my father-in-law, we've all signed consents removing all privacy restrictions from the sharing of our data. So everything I tell you is public information. You can tweet it or put it on YouTube or whatever you want. It's completely fine. 2 weeks ago, my wife came to me and said, something's not right. I said, well, what? She said, well, I had this unexpected weight loss of a couple of kilograms. It's always hot in the room. My heart rate is always over 100, and my eyebrows are beginning to thin. Now, I don't know how many MDs we have in the room, but I've just described the exact specifications of hyperthyroidism. That is, in effect, your body's on speed. Your body melts away, your heart is racing, you can't sleep, you feel fatigued, your hair starts falling out, etc. And she has no particular risk factor or family history for this. However, what's interesting about her and I is that, as quantified self people, we are measuring telemetry about us and can share that with our caregivers where it's relevant. So we're able to document that her heart rate, which is normally 60 to 70, did in fact have a material increase over a couple of weeks. So she did what any of us would do, which is she contacted her clinician electronically, because who wants to drive? And said, here is a set of heart rate changes that have been measured over time, combined with a set of subjective symptoms based on things like inability to sleep, fatigue. Oh, here's the objective data on weight, because again, that's all gathered electronically. And the physician said, what, I think this is probably hyperthyroidism. That's likely what it is. So let's order a TSH, a T3, and a T4, and let's see what that result indicates. We have shared all the data with our patients, lab data, problems, meds, EKGs, images, since 1999. And so she was able to see within 24 hours the fact that her TSH was unmeasurable, and her T3 and T4 were 4 or 5 times what they should be. So in fact, she had hyperthyroidism. But now, of course, the question is, what kind of hyperthyroidism? Was this something that was caused by an immunologic process? Was there a tumor? What was going on? PCP does an electronic referral to an endocrinologist. The endocrinologist reviews the case and all the objective and subjective data and says, well, actually what we need is a thyroid-stimulating immunoglobulin, a TSI it's called. And so that test was ordered. Again, the PCP, the specialist, and my wife are all convening around this data electronically. The TSI comes back at 5 times normal. So the diagnosis is made electronically of Graves' disease. And Graves' disease is treated with either surgery, ablation of the thyroid with radioactive iodine, or a medication. My wife, in understanding the literature, because electronically the PCP and the specialist and my wife are actually reading, there's a beautiful case on the National Library of Medicine, describes a patient just like my wife, and the treatment options and risks. The specialist prescribed the medication which was delivered to the Walgreens pharmacy 50 feet from my farm. And my wife went and picked up her medication. She's on it today, and it'll take some weeks before the symptoms ameliorate. But this just illustrates how if you take a team of caregivers and the patient and build appropriate tools, you can actually achieve great outcomes, high quality and low cost. And this is, again, a real example from the last 2 weeks. When I was last in Toronto, I mentioned my own personal example, which is that I suddenly developed essential hypertension and no one could quite figure out why. My phone was gathering my blood pressure data and sending it to our care management medical record, where the benefit of the care manager and the PCP I have could look at it. And the diagnosis of essential hypertension was made after reviewing some lab results, medications were prescribed, and today I'm normotensive. So these are the kinds of ways one can use analytics and gathering data from a variety of sources. But there's more that you can do with big data analytics. Now, I think Dennis asked me to be careful because big data analytics can be a little bit overhyped, right? It's half technology and half mythology. It turns out it will solve all your problems. Well, not exactly. But here is a case example. And this was that Harvard Business Review article I wrote a couple of weeks ago of where looking at longitudinal population health data was very helpful to my wife. She was diagnosed with stage 3A breast cancer in December of 2011. And of course, an interesting question is, if you look at 10,000 patients like her, Asian female, 50 years old, what were the treatments? What were the outcomes? What were the side effects? So we actually did this exercise. Now, for those of you who are familiar with Harvard, Harvard has 17 hospitals, most of which don't like each other. Partners, healthcare, it's a one-word oxymoron. The MGH and the Brigham, no, don't get along so well. But we agreed that even though we're not going to pool data across all these competitive hospitals, we are going to make available a query tool that enables a researcher to send a question to the data and get a result back. This is not patient-identified data. The questions might be, of all 50-year-old females seen in the last 10 years with this diagnosis, what medications were given? And so you now get a sense, looking at morbidity, mortality, what was prescribed, et cetera, what seems to have worked in the past. So in the case of my wife, we decided that there were 3 medications that she should receive, and one of them was a medication called Taxol. The challenge we found out from the data, however, is a lot of the patients, though successfully treated with Taxol, ended up with no feeling in their hands and feet, because Taxol has the nasty side effect of killing your nerves as well as your cancer. So then we look at literature. We look at pooled clinical trial information. All this is available on the web. It's all public information. And what it says is there's actually been very few clinical trials on the right dosing of Taxol. Just so happened that 9 doses was the clinical trial done 10 years ago, and therefore 9 doses is what's given to every patient. Does 4 doses work? No one knows. Is 13 more effective? No one knows. So what we decided to do in consultation with her hem-onc team was to treat her with half the dose of Taxol, because in her case, her desired outcome was cure plus hand function. She is a visual artist. It was very, very important to her quality of life that she end up with treatment resulting in her ability to continue to create art. We, of course, recognize that if there wasn't a cure, that we would have to consider going to the usual protocol of Taxol. But we followed the rest of the protocol for this breast cancer treatment completely to the letter. Over the course of her appointments, over the course of her treatment, surgery, and radiation, with half the dose of Taxol, she achieved complete cure. Ended up with just a little neuropathy in these 3 fingers, but generally very good function. All of this occurred because we were able to mine the rich database of patients like her who had previous experiences, good and bad, to figure out how to direct her therapy and how to potentially change her therapy. So since Canada has such rich data, I mean, think about, from a privacy perspective, asking a generic question like, of all patients in the last 10 years with cancer, what meds did they receive, isn't going to violate anybody's privacy. We do have to be, of course, very careful as we make tools like that available, that we do have policies and procedures in data governance. So let's just say that there is, not that anyone in here is nefarious, but if there is a nefarious hospital CEO who says, I'm going to ask questions like, of all patients in this postal area, who got surgical site infections? And now I'm going to create a map of all the hospitals, and I'm going to publicly identify my competitors that have bad outcomes. I mean, you have to agree, you're not going to use the database for marketing. You're not going to use it to embarrass your competitors. You're not going to use it, I don't know, are there any pharmaceutical representatives here? Okay. You're not going to sell distributions of name brand prescribing distribution by doctor to Pfizer, right? I mean, so there have got to be some rules of the road. But what we found is when we brought our patient family engagement council together, and we have patients involved in all the steps that I've talked about data use and creating some of our new infrastructure, they all said, you know, if you're looking at de-identified population-based statistics with numerators and denominators, I don't care. You know, you don't need to ask my consent to simply count me in a numerator and a denominator. I mean, of course you'd have to ask my consent if you wanted to enroll me in a clinical trial, if you wanted to in any way identify something about me, like, yes, I have an unusual characteristic, and therefore the publication of a numerator and denominator on one-eyed, green-eyed, blue-eyed people, that would identify me. So we're never going to do anything like that. So I think if you just look at our experience thus far, the big data analytics activity has been very focused, I heard that word used by the last group, on use cases that had very specific impact on our ability to deliver quality and safety and efficiency in each of our care sites. We did not try to boil the ocean. That is, sometimes in the US government, and I have done Federal Advisory Committee service, people in the House and Senate say, the definition of interoperability is the use of every data element in the EHR for every purpose by every stakeholder with little effort at no cost. And if that's your definition of big data analytics, you will fail miserably. You know, create some focused use cases, as was said by this last group. Is it going to be disease specific? Is it going to be, you know, you're going to reduce hospital readmissions. You're going to reduce incidence of MI. You know, are you going to reduce obesity or hypertension? You know, something that is going to give you the data gathered and tool set to accomplish a specific goal. I heard a few things in the discussion this morning that I want to at least give you the US experience, whether it's right or wrong. You know, we spent $31 billion on electronic health records over the last 8 years. Can't say that we got it all correct. We have right now in Congress a variety of bills pending called the Criminalize Information Blocking Bills. Because this was said this morning, you know, penalties for sharing too much, privacy violations, should there be criminalization for sharing too little? I will be very honest with you, I have never seen an organization or a vendor withhold information when there is a business purpose for exchanging that information. I've seen incompetence, you know, that is, we don't technically have the skills to get the information out and exchanged, but I very rarely see volitional information blocking. I guess what the United States did that was successful is by aligning incentives, you get paid for quality. You get paid for outcomes. Suddenly the idea that, oh, it's my data and I can't share it goes away. Because unless the Mass General Hospital and Beth Israel Deaconess share data with each other, we can't manage patient wellness. It becomes an existential issue. If, as an organization, you will only be paid when the patient benefits, data sharing just happens. And it's generally my feeling that if there's a business case, if there's an economic incentive, it isn't really that you have to wait on the standards or the technology. I mean, those are necessary, but they're not sufficient. Business just happens. One of the enablers for us, and I'm sure it's very analogous to Canada Health Infoway, is that the state of Massachusetts chose to create an information superhighway for healthcare, which had a set of guidelines. It had a set of business associate agreements. It had a set of participation agreements. You knew who to trust. You know the appropriate uses of the data. It had a standard patient consent model that we used across the entire Commonwealth. And we provided a facility for getting data from place to place. Now, of interest, we at the state level didn't tell you what data to exchange. We just gave you a very simple way to exchange data of almost any type, as a business case would justify from place to place. And that's what's enabled some of these things that I've talked about. This quality data center, the idea of sending patient healthcare data into the care management medical record, the idea of doing event notification. In the United States, there are a lot of companies that are offering big data analytics. And I say that a lot of these products are compiled in PowerPoint. It's a powerful development language, really, very, very flexible. So I want to hope that Canada doesn't have this problem that we have, which is a lot of entrepreneurs who are going out and promising you the world. You know, I'm going to take your big data analytics, put it in a cloud, make it mobile enabled, and all your problems will go away. As I described, we worked incrementally. We worked to build our quality data center and these various tools I've described based on daily, hard informatics work to get better and better. There wasn't one vendor we could just go to, sign up, and suddenly all these problems went away. So alas, you know, big data isn't a panacea. I think in the examples that I've highlighted, my personal health issues, my wife's health issues, it certainly turned out to be extraordinarily helpful. And as we go to the future, what was also said this morning, there will be more sources of data. There'll be genomics. And what do you do with that? What do you do with biomarkers? How do you include it in your data set? Well, example, and some of you in the audience know, I was the second human sequenced in the Human Genome Project. So my genome is publicly available data. All biomarkers, my stem cells, my microbiome, everything is publicly available. My doctor, in being able to look at this big data analytic of me, says, you're a vegan. You have no exogenous source of cholesterol. Your biomarkers indicate you have no significant heart disease or stroke disease risk. I am not going to order cholesterol on you ever again. Why? It's purposeless. However, you have a significant risk of prostate cancer. The New England Journal suggests that we shouldn't order PSA testing because it hasn't affected morbidity or mortality on the population of males over the last 10 years. But wait, I have a significant risk. So he says, oh, well, if you've got a biomarker that says prostate cancer is a big issue for you, probably I should order a PSA on you. So in effect, the 3 billion base pairs of me, a kind of big data, is now steering my primary care doctor's lab ordering behavior. And that kind of thing you'd expect will be more common over the next couple of years. It's early. It's not quite yet institutionalized in EHRs or in many of the tools. Finally, last point, while I was flying here this morning, I sat next to the CFO of a company called Wolters Kluwer. I own no stock in any company. I have no conflict of interest, don't worry. But we were talking about the fact that Wolters Kluwer is this multinational company that provides vast amounts of data. Unfortunately, they're not at a point where they're yet providing wisdom. And it was to the point where people said this morning, here's a 200-page blood pressure guideline. Who's going to read it? Nobody reads this stuff anymore. What Wolters Kluwer needs to do, and I think other companies, entrepreneurs in the audience need to do, is be able to say, you have a patient in front of you. They're on these meds, they have these problems. What is the right blood pressure medication to order because this patient is a unique individual? And that is a different kind of big data. It's what I'll call a decision support service provider, where we send certain data elements about the patient to the cloud, and a service provider returns us actionable advice. And so I think that's going to be another new frontier for the big data side of what we need to do. So last thing, because I know we want to get to Q&A and we got to get done by 2. You guys said there were certain things you should do by Monday. And I would just be a little bit careful. I would hope that this group, based on your 2 days of meetings, would be able to describe a few great use cases, the minimal data elements necessary to complete those use cases, and then proceed incrementally and then build on your success. Because every time the federal government has had too much regulatory ambition, we've actually alienated the providers, we've broken the provider-patient relationship, and we've actually slowed progress. So anytime you want to hear about our mistakes, I'm happy to share. So let me open it up for questions from you, and of course you can ask me anything about Obamacare or Halamka. I'm expert in both. You're welcome.
We've promised to let people out of here at 2 o'clock, and I know that Brent and Dennis maybe have a couple of sort of housekeeping things, but any questions from the floor? I guess maybe I'll just put one then, John. I mean, one of the suggestions that came up from the panel before lunch was this piece about involving patients in any planning initiative and any kind of change initiative. And it sounds like you've got quite a lot of experience of bringing patients in to give advice and give decisions. I'd be interested in any insights you have on what worked, what didn't work, and whether, in fact, because it seems to me that part of that is actually a culture change, what lessons there might be from your experience with Beth Israel Deaconess on that.
Sure, so 2 threads on that. Sometimes those folks I work with in the informatics world have been a little bit upset on the way I've approached consent, which is I've said the patients should give us express opt-in consent to use their data and understand what we're going to do with it before we use it. And again, when it's completely aggregated and anonymized, I mean, there's not so much issue there. But if we're going to be sending data to a whole variety of third parties for a variety of analytic purposes, there should be some disclosure about that. What I found is, over the course of the last couple of years, 97% of patients in the Commonwealth of Massachusetts have opted in to share all their data for all purposes because they recognize it's going to ultimately benefit them. And the Boston Globe writes these glowing articles about how we've engaged the patients and asked their permission, as opposed to some cities, some countries, like the UK, just started using your data without asking you, and the press trashed them, and the projects were shut down. So if you think it's hard to ask patients' involvement first, it's actually easier.
John, thanks very, very much for a very lively and engaging presentation. Appreciate you joining us.